This 48-year-old man has had a growth in his mouth for the past 4 months. This lesion is conspicuously located on the dorsum of the tongue. It is a grayish-white, slightly raised papillary tumor measuring 1.5 by 1 centimeters. It is painless and has not interfered with the patient's swallowing or speech. Upon palpation, the lesion is found to be indurated with a slight degree of fixation to the underlying tissues. There is no palpable evidence of lymph node involvement. This examination, performed during a routine dental checkup, aroused a suspicion of cancer, later confirmed by pathological examination. However, because this growth was found in a relatively early and localized condition, the patient's chances for cure are excellent. If this man had not presented himself for a routine dental examination, and if his dentist had not recognized the possible malignant nature of this lesion, this patient, like most others with mouth cancer, might have continued to neglect or ignore his disease until it had progressed beyond any hope of cure. The recognition of mouth cancer is a responsibility shared by the dental and medical professions. In this motion picture, 6 common sites of oral cancer will be discussed: the gingiva or gum, palate, tongue, cheek, floor of the mouth, and lip. All of these sites are readily accessible to inspection, palpation, and biopsy, and therefore susceptible of early diagnosis and treatment. Despite this ready accessibility, a breakdown of the oral cancer problem reveals that the majority of these lesions are not recognized at a time when satisfactory treatment can be accomplished. In one series studied, the 5-year cure rates for all patients, both early and advanced, were gingiva 32%, tongue 30%, floor of the mouth 19%, palate 30%, cheek or buccal mucosa 24%, and the lip 67%. Taking the picture as a whole, the overall 5-year cure rate for these anatomic sites was 32.5%, roughly 1/3. The fact that this end result can be greatly improved through the earlier recognition of oral cancer is illustrated by selecting small lesions from the above cases. The 5-year cure rates for patients from the same series with lesions less than 2 centimeters in size were gingiva 38%, tongue 55%, floor of the mouth 50%, palate 57%, cheek 60%, and the lip 86%. In this series, the composite picture for patients with lesions less than 2 centimeters in size shows an average 5-year cure rate of 57%, or nearly double the cure rate of oral lesions regardless of size. By comparing these two groups, it is evident that only by the recognition of mouth cancer in an earlier stage can ultimate improvement in the control of this disease be achieved. Who is responsible for this earlier recognition? As illustrated in this typical case, most patients ignore or neglect early oral cancer because it suggests a benign transitory condition which they have safely ignored before. Many malignant oral lesions can be differentiated from benign conditions only as the result of a thorough clinical and pathological examination. Whether performed by the dentist or by the physician, the technique of an oral examination should be uniform and its purpose identical: to detect any abnormality in and about the mouth which may possibly be neoplastic. The examination should be preceded by a careful and detailed case history. However, the examiner should bear in mind that a history of no complaint may be misleading and does not do away with the necessity of performing a thorough examination. The patient must be seated upright, in a good light, with adequate exposure of the anatomy. In carrying out this examination as a routine office procedure, the instruments required are familiar to both the physician and the dentist. These are tongue blades or tongue depressors, rubber gloves or finger cots, and oral mirrors of various sizes. With this simple equipment, an adequate examination of the oral cavity can be accomplished by a combination of observation, inspection, and palpation. The anatomy of the normal head, neck, and mouth is symmetrical, and the examiner should be alert for any significant asymmetry. The lips are inspected first. The normal lips in repose are symmetrical. The mucosa is soft, vermilion in color, and clear. Any deviation from this picture should arouse suspicion of underlying disease. There follows a progressive examination within the mouth itself. If dentures are present, they should be removed. The tongue is protruded and carefully inspected for color, texture, and symmetry. It should be observed for any sign of discomfort or limitation of motion. Adequate inspection of the tongue requires that it be grasped with gauze and pulled forward to expose its lateral borders with a tongue blade retracting the cheek. The lateral borders adjacent to the molar teeth are the most common sites of cancer of this organ. The base of the tongue is examined later by mirror and palpating finger. One of the most neglected steps in cancer detection, and its importance cannot be overemphasized. Here again, an orderly procedure will include all areas of the mouth and will provide the examiner with a maximum opportunity to detect any area of swelling, roughness, induration, or asymmetry, the cardinal signs of suspicion when feeling for cancer. Moreover, palpation will often elicit bleeding in the presence of cancer, and this should be watched for. An important but frequently neglected step of this examination is inspection of the nasopharynx. This can be accomplished readily by depressing the tongue and passing a small mirror gently behind the uvula. With adequate care, a gag reflex can usually be prevented, or the palate may be sprayed with a topical anesthetic. The patient is directed to breathe through both mouth and nose. This maneuver relaxes the soft palate, exposing the nasopharynx to good visualization. Another frequently overlooked site of accessible cancer is the base of the tongue and the larynx. The early detection of disease in this area is made possible by mirror examination. This simple office examination is the only means by which either physician or dentist can inspect the base of the tongue, the epiglottis, the vocal cords, the lateral pharynx, and the hypopharynx. By warming the mirror, fogging is prevented and good visualization is sustained. And now, deferred until last for the patient's comfort, is deep palpation of the mouth. This includes the soft palate, tonsils, tonsillar pillars, pharyngeal walls, and base of the tongue. Although inspection and palpation of the oral cavity and its contiguous structures may reveal no evidence of disease, examination of the patient is not complete without reference to the neck. For a frequent first sign in oral cancer is a lump in the neck, which is in most cases cancer metastatic to a lymph node. Anatomically, there are 5 major secretory glands in the neck: the paired parotids, the paired submaxillaries, and the thyroid gland. Although these true glands may be the sites of primary cancer, the usual lump in the neck of neoplastic character is due to involvement of the lymph nodes of the neck from a primary focus within the mouth or pharynx. For this reason, the examiner should be familiar with the principle symmetrical. It can conveniently be demonstrated on one side of the neck. The principal lymph nodes which the examiner should bear in mind are the submental group, which drains the superficial tissues of the lower lip and anterior gingiva, least frequently involved by metastatic cancer. The submaxillary group, which drains the superficial tissues of the cheek, buccal mucosa, and gums. The preauricular and parotid groups, which drain superficial soft parts of the lateral scalp and face, the lateral canthus of the eye, and the conjunctiva. It is noteworthy that cancer of the upper lip frequently metastasizes first to the preauricular lymph nodes. The most common site of metastasis is to the subdigastric nodes, sometimes referred to as the tonsillar nodes. Actually, these are the master nodes because they receive drainage from the entire oral cavity, including the lateral pharynx, tonsil, piriform sinus, and larynx. This is the most superior group of the internal jugular chain. The internal jugular chain lies directly beneath the sternomastoid, following the course of the internal jugular vein. This group drains all of the deeper structures of the neck, including the larynx, thyroid gland, cervical esophagus, and all other nodes previously described. The most inferior group of the jugular chain is associated with the thoracic duct on the left and with the lymphatic duct on the right. These nodes receive drainage from above and below the clavicle, and they lie between the sternal and clavicular heads of each sternomastoid. Finally, there is the posterior cervical or spinal accessory chain. This receives drainage mainly from the nasopharynx, scalp, posterior neck and skin, as well as overflow from the jugular chain. Although it may not be necessary for the examiner to memorize the details of the lymphatics of the neck, his examination should be sufficiently methodical and broad to include all of these important groups. Thus, by following such a pattern, he palpates the submental, the submaxillary, the parotid and preauricular, the superior jugular chain along the course of the sternomastoid, including the subdigastric nodes above, down to the inferior group of the jugular chain, best felt by two deeply placed fingers, and finally the posterior cervical or spinal accessory chain. The examination is repeated on the opposite side of the neck, following the same methodical pattern. Only by adhering to such a routine can the examiner be sure he has felt individually all of the important node-bearing areas. The normal node is a flattened ovoid, somewhat bean-shaped. The abnormal node is globular or spherical. Normal nodes can be palpated in thin individuals and children. By comparing the two sides of the neck simultaneously, any enlargement of the nodes on one side can be more readily detected, and this enlargement is usually important. As a final contribution to the earlier detection of cancer of the mouth and neck, the thyroid gland is palpated by displacing it to one side and the other as the patient swallows. And now, after a 10-minute examination, this man can be ruled free from any clinical evidence of oral cancer. In this motion picture, 6 anatomic sites of oral cancer have been discussed. The importance of earlier recognition of this disease has been emphasized, and the technique required for this recognition has been illustrated. Although cancer of any of these sites can be finally proved only by histologic examination, the clinical recognition of early cancer of these sites can usually be made by the gross appearance of the lesion, together with its history of onset and particularly its persistence, as evident in the selected early cases which follow. Case number 1, cancer of the gingiva. 1 month ago, this man complained to his dentist that food persistently stuck in his left lower molar teeth. A routine occlusal film taken by the dentist revealed an impacted third molar tooth. Before attempting an extraction, diagnosis of syphilis. Case number 7, the lump in the neck, a first sign of mouth or pharynx cancer. This 54-year-old man relates a fairly common and unfortunate series of events. 3 months ago, he noted a painless swelling change overlying the left posterior gum and ascending ramus. Because of the granular appearance of this lesion, its lack of pain, and most particularly its induration, the dentist suspected cancer and referred the patient to a surgeon. Subsequent biopsy proved this to be an epidermoid carcinoma of the gingiva. Case number 2, cancer of the palate. This 57-year-old physician has noticed a soft, painless submucosal swelling in his hard palate for the past 6 months, which he had ascribed to infection of a minor salivary gland. 2 weeks ago, this lesion underwent a degenerative change and appeared as a shallow, punched-out ulcer with a necrotic base. This ulcer is painless. However, it failed to respond to any form of local treatment and aroused in the patient himself a suspicion of possible cancer. Clinical examination revealed the ulcer base to be firmly fixed to underlying tissue and to have a rolled nodular border. This lesion was subsequently identified histologically as an adenocarcinoma of minor salivary gland origin, as the patient had suspected. Case number 3, cancer of the cheek. This 57-year-old shopkeeper has had leukoplakia of both cheeks for many years. He is a moderately heavy smoker, the Mazzini is negative, and he gives no history of injury to the areas in question. In the right cheek, there is a zone of diffuse leukoplakia. During the past several years, this has shown no tendency to undergo any suspicious change and is characteristically soft and superficial to inspection and palpation. Clinically, this may be described as uncomplicated leukoplakia. However, on the opposite cheek, a different clinical picture is found. Here is a papillary tumor, cauliflower-like in appearance, which arises in an area of leukoplakia. This lesion occupies an area in the posterior gingival buccal fold and measures approximately 2 by 1 centimeters. It is typically fissured and bleeds on slight trauma. It is mobile over the underlying ascending ramus. The clinical picture suggests cancer, a suspicion later confirmed by biopsy. Case number 4, cancer of the tib. The patient smokes a pack of cigarettes daily. 1 year ago, an area of leukoplakia was excised from the dorsum of the tongue. 3 months ago, his dentist noticed a granular change in the mucosa of the central third of the tongue. This was painless and did not interfere with speech or deglutition. The lesion is irregular and measures about 2.5 centimeters in length and 1 centimeter in width. Although most lingual cancers occur on a lateral border, this lesion was suspected of being malignant on the basis of its onset and duration, as well as its firm consistence and fixation noted on palpation. The diagnosis was later confirmed by histologic examination. Case number 5, cancer of the lip. This 48-year-old elevator operator has noticed a sore on his lower lip for the past 2 months. There is no history of trauma, tuberculosis, or syphilis. The patient has smoked a pipe for many years, habitually gripping the stem on the right side of his mouth. Examination now reveals an area of diffuse leukoplakia in vision, which has failed to heal for 1 month. In addition to a suspicious onset and duration, this lesion is located on a lateral border of the lower lip a characteristic site for cancers of the lip. Gentle palpation reveals induration as well as fixation to the underlying tissues. Although subsequent biopsy confirmed the diagnosis of cancer, this patient did not present any clinical signs of metastasis, which in this case dermoid carcinoma. He was discharged without further study and referred to a cancer clinic. As we see him now for the first time, the only external finding is residual induration in the left upper jugular chain at the site of the recent surgical incision. In this case, there are no symptoms pointing to an internal tumor, but with this setting, there must be a primary cancer, probably on the left side of the mouth or pharynx, and the lesion can be quite small. Here, the primary tumor is readily discovered in the left soft palate. This is epidermoid carcinoma, proven by biopsy, discrete, granular, starting to ulcerate, but still painless. A perfectly obvious lesion unknown to the patient and not sought for by physician or surgeon. This is the primary cancer which should have been found, which should have been biopsied, and which must be controlled if this patient is to survive. Removal of the neck node contributed little to the diagnosis here, and in fact measurably interfered with proper treatment by delay and by scarring of a surgical field where radical dissection might be contemplated. When faced with the problem of an unknown mass in the neck, where obvious lipoma, cyst, or thyroid adenoma can be excluded, open biopsy is a measure of last resort in a series of diagnostic maneuvers which start with a thorough examination of the mouth, tonsils, base of the tongue, larynx, such as this tumor on the lateral undersurface of the tongue, is most conveniently biopsied by and resembles a syphilitic chancre, and the Wassermann is positive. But no time was lost on dark field studies. In the presence of possible cancer, there is no substitute for immediate biopsy. In this respect, it should be remembered that cancer of the tongue is 400 times more common than syphilis in the tongue, and 200 times more common than tuberculosis of this organ. In 10 to 15% of the cases of tongue cancer, there is coexisting syphilis of their complaint. This examination must include careful inspection and thorough palpation, not only of the oral cavity and pharynx, but also of the true glands, as well as the lymph nodes of the neck, quality of color, texture, or symmetry. At this time, inspection is extended to the posterior pharyngeal wall and the tonsillar areas. The same careful scrutiny is now directed to the cheek, including the entire buccal mucosa, the gingivo-buccal gutters, and the gums. There is no substitute for the methodical and painstaking inspection of these tissues. Early cancer is most commonly seen as a small ulcer with local induration, less often as an area of thickening or roughening, or as a patch of leukoplakia with or without any obvious ulceration. In brief, symptoms both subjective and objective may be so slight that the patient may disregard them or be completely unaware of any abnormality. For the same reason, such early mouth. Only by these simple methods, repeated periodically, can the patient with cancer be afforded prompt diagnosis and effective treatment, and the patient without cancer be afforded peace of mind.